of me enough to listen to me for more than 5 minutes. It's truly, it's always a privilege to be given someone's brain space, right? And welcome to everyone across the globe. I've been so happy watching Dr. Uvo's efforts and some of the organized learning that happens in other countries. It intrigues me, it fascinates me, it impresses me time and time again. And so I want to applaud everyone that's on this webinar, whether you're going to be watching it live or recorded version later, because investing in yourself is going to pay dividends in your career, in your passion for what you do, in your patient outcomes, and in your contribution to your surrounding community. Now, not only as a clinician, but as an advocate and as an educator as you progress as well. So, thank you again for the invitation. My name is LeRoy Horton. I'm in the greater Seattle area in the northwest part of the United States. My background, I got my degree in biology from Pacific Lutheran University. I did my dental school training at the University of Washington. I did my periodontal residency at Oregon Health Sciences. I am dual board certified, so I'm a board certified periodontist, which means I have not only progressed through the residency, but I've gone through a battery of written and oral examinations to kind of prove my know-how and my critical thinking and my depth of knowledge. So I'm a board certified periodontist, and I'm also a board certified implantologist through the International Congress of Oral Implantology. Now, those titles in and of themselves don't mean a ton without my ability to demonstrate not only what I know, what I do in clinical practice, the principles with which I actually make my clinical decision making, my contribution to research in this field, and my passion for not only these clinical treatments, but for education. And so I'm hoping that my presentation actually is a greater testament to what I have given to this profession than titles or letters after my name. Let me see. Oh, doesn't seem to be. There we go. Now it's working. All right. A little bit about myself personally. I'm actually not from the United States. I was born and raised in a little suburb of Athens called Glyfada. And with today's technology, I can show you exactly where I'm from. So this is the building that we grew up in. On the base floor, we lived with our grandparents. On the next floor, it was my aunt and my cousins. The next floor, my uncle and my other cousins. And the last floor, my other uncle and my cousins. In Greece, it's a pretty densely populated country, a very small country, and so families tend to build up instead of spreading out. And so actually this whole block, there was a lot of direct and extended family from cousins, second cousins, and so forth, all within walkable distance. This was me in the middle, the little chocolate baby amongst a my family in Greece. We immigrated to the U.S., me, my mother, and my brother when I was 13, and we landed here in the Northwest. I'm an avid adventure seeker, so I'm always out there doing physical activities. This is a buddy of mine here named Kevin Suzuki, who's a fellow periodontist out here in the Northwest, but we do a lot of Spartan races together. And in a different life, I used to climb in cages and rings and get punched in the face for fun. So I'm a bit far removed from that. I still train, but I haven't competed in a while. This is my beautiful family. This was a picture in Greece when we went back for my cousin's wedding. Flash forward, everyone's all grown up, beautiful wife, three beautiful kids. And I believe we were in Mexico when this picture was taken. Now, I did say I did my periodontal training at Oregon Health Sciences. So this is the view from my residency room on the left, and this is the view of the building on the right. It was a great experience because in that time I made a lot of connections, a lot of great friends and colleagues. We also did a lot of research. So whether it was clinical research with live patients, whether it was research in the cadaver lab in the morgue, Uh, we had a couple publications come out at this time. We got one that's actually pending come out. This one here was actually published last year, and we were looking at the amount of heat generated in different spin protocols of different drills. And I'm a avid nerd, so I'm always writing a lot of CE courses. So if you ever have come across the Dental Town platform, and become a member, you have access to a lot of CE articles, and I've been an avid writer of CE articles over the years. So that's a great extra place to get education, whether it's this platform or another one. But continuing education doesn't always have to be webinars. It can be reading articles. It could be reading literature. And a lot of the publications and magazines will have CE courses where you read, answer questions, and you get CE credit that way as well. And currently, I'm Director of Periodontics and Implants at Pacific Northwest University of Health Sciences, School of Dental Medicine. So my job is to train dental students in the world of periodontics, both surgical and non-surgical, as well as implantology. But enough about me. You're here to learn about socket preservation, the healing process, from extraction to final product, and how we can help control the biology to give the patients the best possible outcome. Now, through this lecture, I want to be very fair. You will hear speakers that might be experienced clinicians. Just because you can do something to whatever degree of competency doesn't necessarily mean that you're a good teacher. And what I want you all to look for when you are navigating your career and you are fielding different experts that are coming to talk to you, always make sure that if anyone is teaching you something, they back it up with scientific literature. All right, there's got to be a basis for what we do. It can't be opinion or just opinion. It can't be just, this is how I was taught, so this is how I do it. If someone is giving you an honest lecture, they'll present you from their personal experience and their cases and so forth, but they're going to back it up with some sound scientific basis for what they do. And not only then do you have to look at what's the scientific basis, you want someone to be able to demonstrate thorough clinical presentation. And so the cases you will see from me, they're not half cases. They're not day of surgery cases. These are start to finish. We started at point A, and I'm showing you the point Z product because I want you to trust that what I'm saying has basis not just from science, but from my actual finished results. And I think that's very, very important as you're navigating your profession and you're coming across a lot of speakers that will be before you teaching you some of these concepts. So let's talk about the healing process. Now, when it comes to an extraction socket, we have a lot of good data. This is one of the classic papers that's quoted, is one from Schropp, that pretty much details how in the first year or so, you're probably going to lose about 25% of the volume of your socket if you just do what's called unassisted healing. So you take the tooth out and you didn't do any bone grafting, you just let it close. The body is going to shrink. Okay. That ridge is going to lose a certain amount of volume. Now, within the first 3 years, you can lose up to about 40 to 50% of that volume, which in some cases may or may not be catastrophic. But if we're thinking about wanting to potentially place implants, or even if you're going to do a fixed partial denture, having more volume so you're not compensating with that extra or for that extra space with restorative material is going to give you more cleansability or enhanced cleansability, enhanced aesthetics, and it's going to be easier for you and your lab to actually fabricate this restoration. But if we look at what happens when we do nothing, then yes, we're probably going to lose in a lot of sockets upwards of 50% over the first 3 years. And when you look at this Araujo study on this image on the bottom, it's actually a dog study where they were able to do histology of extraction sockets at different stages. And what you see on the left early on, you get a blood clot, you get what's called a provisional matrix, which is that granulation tissue, that amorphous gel that's within a socket early on. By 2 weeks, you still have that granulation tissue, but you're starting to get some new early beginnings of bone formation. So that WB that you see there stands for woven bone. But you can see even from 1 to 2 weeks, that socket generally has started to decrease a little bit. And it almost always starts to decrease more so from the buccal aspect. Now, why is that? Well, if you look at the lingual and the buccal on here, the buccal tends to be thinner, especially in the anterior in humans. And the less thickness you have of that buccal bone means the less medullary component and the less blood supply. So if you're already taking out a tooth, and we know that the majority of the blood supply of the medullary bone comes from that periodontal ligament. Well, you took the tooth out, so we destroyed the periodontal ligament. You might have laid a flap, so you've disconnected the periosteum, which supplies about 80% of the blood supply for the cortical bone. So everything we've done so far in taking this tooth out is an ischemic attack. We're compromising the blood supply. So areas that have, like the buccal, less of a natural thick internal blood supply because it's thinner, it has less medullary bone where those blood vessels are, those are we're going to see shrinking, remodeling, and sloughing, right? Necrosis of that tissue. And so although the ridge collapses almost in all dimensions, is going to collapse more so on the buccal. And you see by 8 weeks how much remodeling we've had if we have what's called unassisted healing. We have done no grafting to reserve that ridge. Now, in some cases, we may technically still have enough bone for an implant. And we've all had those patients where you've extracted a tooth, you didn't do bone grafting, you come back and the ridge is still really wide. Okay, and this is one of those examples. We technically have enough bone for an implant. But remember, we don't just want to put an implant in bone. We want to put an implant that has good bone support, but is placed in a restoratively driven position. That's extremely important. So sometimes planning ahead with ridge preservation almost always guarantees we'll have enough bone to put the implant in a restoratively driven position. And other times, like in this case here, if we look at the contours of where the natural teeth are on either side, and we estimated where this restoration would be, we can see that this implant would be off axis, right? Ideally, it would be centered. Now, it doesn't mean we can't do it, but it does mean we're compromising here. We might have to tilt the implant, which puts shearing non-axial forces on that implant, and especially in a molar position, could potentially lead to inflammation, prosthetic complications, because implants ideally work in an axial force environment. Now that's posterior healing. In anterior, that Schropp study was an older study that was using models, right? So they would take a model before, take a model after, measure the difference in dimensions. Well, nowadays we have CBCT at our disposal, so we can actually see what happens in 3 dimensions. This is a great study by Chapui where they looked at extraction sockets that were not healed or not grafted, so unassisted healed sockets. And what they found is that if you were to break up the anterior portion or the buccal portion of these sockets, and you see here in the center, right, of this extraction socket being the most vulnerable, the average loss of a buccal socket after extraction without grafting was about 5.2 millimeters of vertical loss. So if you look at this bottom picture here, right, it maps out horizontal and vertical loss. The average in anterior without grafting is 5.2 millimeters. Now you can imagine we're placing in general, what are you placing? 10 millimeter implants, right? And so you can see how even though we're talking about millimeters, in the world of implantology or periodontology, millimeters are miles or kilometers. Um, that's how important each millimeter is. And so if we can somehow prevent this, it's only going to benefit us and the patient as well. Now, it's important to note that a large part of this is because the buccal plate on anterior teeth tends to be really thin. So almost 70% of your patients, that buccal plate is going to be less than 1 millimeter. And I think in a few slides, I actually quote a Fugazzotto article that states that if your buccal thickness is more than 1.5 millimeters, then in general, you don't see much shrinkage, right? Because it's enough to have a robust medullary component and an internal blood supply. So you see a lot less shrinkage. But in the anterior, the vast majority of your patients are not going to have anywhere near that. Okay, so 70% of your patients are going to have less than 1 millimeter, which makes grafting in the anterior very, very crucial. So if we look at this from the same Chapuis study, you look at this plot graph and you can see at 1 millimeter, as you go greater than 1 millimeter, so as you track your eye to the right of center, and then you note that the left is percentage of vertical bone loss, you're in the 10 to 20% if your facial bone thickness is greater than 1 millimeter, right? Which, again, that's only 30% or less of our patients. The vast majority of our patients are less than 1 millimeter, and you look here. Sometimes you're upwards of, starting anywhere from 40% bone loss upwards to 100% bone loss of that buccal plate. Okay, so it's important as you start taking these classes and you're learning these concepts, you're developing this understanding of being able to predict biology, given what the data shows, and being able to provide an accurate and thorough risk assessment for your patients. How risk, um, how high is the risk of this patient for losing bone if I do nothing, right? If the patient is on the fence, maybe they can't afford the grafting, maybe they can. Doc, do I really need it? Can we wait? Can we do it later? You need to be able to look at your patient and assess how high risk they are and how that is going to impact their desired future outcomes. If they have absolutely no desire for implants, then even if you offer it and they decline it, then you can rest easy, right? You can say, okay, well, they don't want implants. I tried my best to talk them into at least the grafting, but they didn't want it. Now, if someone says they do want implants, but they're on the fence on whether or not they want the bone graft, you have this data to arm your insistence and say, sir, ma'am, if we are going to do this, if you're going to stick with me for your future implant therapy, I must insist 100% that we do grafting today at the time that we take this tooth out. And this is why. And you'll be able to explain to them why. Now, remember, once you take a tooth out, and we'll go over some extraction strategies here soon, that socket needs to be degranulated. So you want good, clean bone on the inside of that socket. Healing process, once you do that, can occur in typically two different ways, whether we're talking about periodontal defects or extraction socket defects. Regeneration is a term that you're going to hear, which usually is used to refer to the healing of the complete bone volume without any limitations. Okay. Now, regeneration, when we're talking about periodontal therapy, is going to be a little more nuanced and specific to that. But as far as extraction healing, typically when you hear regeneration, it means we've extracted the tooth, we've done a bone graft, and we've retained most all of that volume. Okay. So we're not going to have any functional limitations, especially when it comes to future implant therapy. Repair is usually what happens when we get incomplete bone volume to form in a residual ridge. And you can see from these two images here, in one, we're able to retain a ton of volume. That is a very, very thick, beautiful ridge. In the lower, and presumably in this case, there was no um, bone grafting done. We had repair, right? There was healing, right? It's bone in there, it's gum tissue, but what we have is inadequate and incomplete volume retention from where that original ridge was. Okay. Now, to understand why that happens, let's look at the healing process. So if I take a tooth out and you see here tooth extraction day one, as I've stated before, we have an empty socket. We've ripped out the periodontal ligament. If you've laid a flap, you've disconnected the periosteum from the outside of the cortical bone. And typically what you can expect in day one is just a blood clot if you don't do any bone grafting. Now, what's going to happen is in the first few weeks, we're going to start seeing new blood supply form. And always remember, if you can't get blood there, you can't get bone and you can't get soft tissue. So one of the things that we strongly focus on is how can we craft our approach to minimize the disruption of blood and facilitate and assist the regeneration of a blood supply as fast and as healthy as possible. But now you can see from this 1 to 3 weeks, and even from 3 to 4 weeks, when we start getting new bone formation, because the medullary bone is where the majority of the pre-existing blood supply is, that's where you're going to get the initial formation of your new blood supply. It's going to be at the apex. Now, as the bone forms, if the blood supply is coming primarily from the bottom, where that thicker medullary bone is, and there's a lot less coming from the superior part of the socket, you can understand why we see bone form in the upwards direction and remodeling and shrinking happen from a superior to an inferior, right? Bone is going up while shrinking is coming down. And in about 4 to 6 weeks, you can see here we've got not only new bone formation, but we're starting to see some maturation, right? Some trabecular patterns, so that that bone is starting to mature. And then typically by the fourth month is when we can expect a fully mature bone socket or bone ridge post extraction. Now, again, the bone formation usually starts as early as the third week, showing the early formations of trabecular and woven bone starting from the bottom. And as the internal bone is forming, the cortical bone at the marginal crest sees resorption because of that deficient blood supply. And that's what happens internally, right? So now, if you can visualize what's happening internally, it's time now to visualize what happens externally. Remember how I referenced that the periosteum is, if you lay a flap especially, is the primary blood supply for that cortical bone. At least on the internal, right, in that internal space, you have medullary bone that's going to offer the blood supply. Well, cortical bone is very dense, it's very non-porous, and its main blood supply is going to be that overlying periosteum. But if we lay a flap, as you can see in this picture, we're potentially disrupting that 80% of blood supply that comes to that cortical bone. Okay, 80% of the arterial blood supply comes from the periosteum, and 100% of the venous drainage actually comes from the periosteum as well. So now you're starting to get the picture. Anytime we do an extraction, we are causing trauma and we are causing specifically an ischemic attack, meaning we're depriving this area of blood and oxygen, which is vital to survival. Okay, not only are you reflecting a flap, you're taking a tooth out. Depending on how long this is taking you, right? This area might be ischemic or lacking oxygen-rich blood supply for 30 minutes, an hour, hour and a half plus, depending on the procedures that you're doing. So it's very important that we're very careful and understand how the biology works so that knowledge can guide our actual surgical strategy. So if we can avoid a flap, it's always preferable. And also realize that your periosteum limits the capacity to grow because it essentially acts as the outermost barrier for bone growth. And so whatever volumes we create and however we manipulate our flaps, we can only grow bone at to the extent of where that periosteum is in three-dimensional volume. Now, again, I mentioned that a Schwab study looking at um, ridge dimensions and shrinkage. And what I always like to do is marry science with reality. So I will talk about the literature and then I'll show you from my own cases. This is a case of mine. If you look in the case of number 19 on the upper right of this left side photograph, it's the area that I did the extraction and I did the ridge preservation. Now, one thing about the human body that gives us some great comparison, or the ability to compare, is that there's tends to be very good symmetry. So I can look at the other side that still has the natural tooth, and I can measure how much, or even just visually look at how much bone volume we had, and I look at the site that we did the extraction, almost identical. All right, we were able to preserve almost 100% of that dimension with bone grafting. Now, if I look at this other site, this is tooth number 28 using the American system of numbering. That was extracted by another provider, and there was no bone grafting done. And you can actually see when we measure it, not only do you visually see that it has shrunk, right? And but we can actually measure it with our measuring tools on the cone beam software. And we talked about how within the first year you can get 25 to 30% shrinkage, and lo and behold, the contralateral side is about 10 millimeters. This side is about 7 to 8. So we've lost about 25 to 30% of our volume without doing any bone grafting, which again may or may not hinder you from doing an implant, but it absolutely hinders you from doing an implant in the ideal restorative position. So to summarize the extraction healing, it's paramount that we preserve alveolar bone whenever possible, regardless of what you're planning. If you're planning implants, fixed partial denture, removable partial denture, or complete denture, having more natural volume is almost always going to be in your benefit and the patient's benefit. It's easier to preserve bone than to grow bone. All right. A lot of the stuff that we're doing is trying to create miracles in the human body, for lack of a better word. Okay. I'm trying to resurrect the dead in this area, right? There's empty volume of space if it's already healed and shrunk. And if I'm doing bone grafting, I'm trying to create bone out of thin air. It's much easier to preserve bone because I already have that volume, right? I already have the walls of that socket to um, to create the boundaries of the bone I'm trying to grow within it. So, of those two miracles, preserving bone is always going to be easier than growing bone. So, it's always in our best interest to preserve bone when possible. Now, Pagney in 2012 discussed the patterns of bone shrinkage when there's no load. We know that bone is able to maintain itself under functional load. That's why we see when someone is rendered immobile, they start to lose density in their bone. When someone goes to outer space and they have less gravity and there's less force on the less load on the bones, they start to lose bone density. Well, if you have a edentulous site that's not taking on the loads of the daily chewing function, it's going to shrink. And now it's going to shrink regardless of whether you grafted it or not. That's something you really understand. You really have to understand. But what happens is if you don't graft, you're going to get that initial, upwards of 50% shrinkage over the first 3 years. Then it'll stabilize. But if there's no load on it, it's going to continue to shrink about half to 1% per year. It remains edentulous. Now, if we do the math on that, if I'm able to retain about 100% of that and lose 0.5% a year per year, confident that whether or not the patient comes back in 5 years, 10 years, at most, I will have only lost 10%, which in most cases is going to be inconsequential, especially in the posterior. But if I don't graft and I'm already starting at 50%, now if I'm losing 1% a year and the patient is coming back 5, 10 years later, I may not have any bone at all or not near enough bone to place an implant. Now I'm going to more than likely going to have to perform the miracle of ridge augmentation when I could have easily preserved so much of that with ridge preservation. Okay. So when you can, preservation is going to be crucial because over time you're still going to get shrinkage, but you're starting from a much greater volume when you preserve it to begin with. Now, I've talked to you about the concept and hopefully have demonstrated why you should be considering bone grafting at every possible extraction, right? Outside of obviously primary teeth. We're not bone grafting primary teeth, but for your adults, you should be considering bone grafting whenever possible. And even for, depending on how you define adults, anytime you're removing an adult tooth without the I guess without being in the context of orthodontics, right? If I'm removing premolars for orthodontics and then we're moving teeth into that space, those teeth are going to bring that bone volume with them. But let's say I have a 16-year-old that's got a decayed tooth, a lower first molar for whatever reason, and we're taking it out. Then even though they're technically a minor, that would be a great case to add the benefit of bone grafting, even though they're not technically adults, depending on the traditional definition. So I've convinced you, hopefully, why and why you should do it and what the benefits are. Let's talk about some of the materials that we're going to be using. Now, some terms that we need to know that are important are osteoinduction, which is the process by which osteogenesis is induced, which implies the recruitment of immature cells and the stimulation of these cells to develop into preosteoblasts, right? So this would be, in its extreme definition, can I grow bone where there's no pre-existing bone? That would be the gold standard of osteoinduction. Can I implant something in the skin far away from the bone and grow bone? That's osteoinduction. In general, the materials we're going to be using are what's called osteoconductive, meaning they provide a scaffold, a surface, a volume by which we can then drive your body to enter into that space and create bone. Okay. But usually for that to happen, we have to have pre-existing bone to some capacity. And so when you're looking at these materials and the advertising around them, some materials will say that they're osteoinductive, meaning they have certain cellular growth signals like bone morphogenic protein, which is a very strong inducer of um, of early cells who turn into pre-osteoblasts and osteoblasts. That would be an osteoinductive biologic material. But most of the stuff we're going to be using is essentially a scaffolding, right? It's a placeholder for your body to form new bone. It's not actually inducing spontaneous bone growth. Now, when we look at grafting materials, your gold standard for most definitions and most textbooks is going to be what we call autogenous bone. So that's bone taken from your own body. In the mouth, typically this happens by us being able to either scrape bone using the bone scraper and collecting those scrapings and transplanting them somewhere else in the mouth. You can actually use bone blocks, right? Some might have to create a separate surgical site, harvest some bone and transplant it into the site where we're trying to augment. That's going to be our gold standard. Just underneath that gold standard is what we call allogenic bone. So it's bone from the same species, but a different individual. So these are typically donor tissue, right, from people, humans that have deceased. The bone is taken, it's freeze dried, it's irradiated. It can be demineralized, but it's treated to get rid of any viruses, of any unwanted, viruses, bacteria. Let me go back here. And any unwanted tissue, right? So in general, what they're trying to get is either some type of, strictly mineralized component, and in some formulations, it'll be mineralized with a component of collagen mixed in. Now, if we're not going to be using our own human bone, and not going to be using donor tissue, right? It could be it's not available. It could be it's not legal in your potential country. And I know in Europe for many years using cadaver bone was not legal. And so a lot of the studies coming out of Europe was either using bovine bone or synthetic bone. But now the market has opened up. where allogenic bone is used in the European countries. But we have xenogenic bone, which is biologic origin, but from other species. And depending on where you're at around the world, you'll see bovine bone, you'll see porcine bone, you'll see equine bone from horses, you'll see camel bone. In the United States, we typically use either bovine bone or porcine bone. And depending on which demographic you're working on, there may be, religious or cultural um, implications that you might have to be aware of, or at least have the patient be aware of, so they can make a decision on which type of material they want you to use. But in general, what you'll see here in the United States is a lot of bovine bone. Now, the good thing about this bone is that it, obviously doesn't require another human being to pass on to be able um, to acquire it. It can be used in the same capacity that we use for all our grafting, but bovine especially, because of its mineral constituency, takes a little bit longer for your body to break down. And remember, this bone grafting material doesn't stay there. Your body breaks it down, but as it breaks it down, it deposits your own native bone along the way. Bovine bone tends to stick around a little longer, which sometimes can be a benefit, sometimes not. Porcine bone seems to break down a lot more along the timeline as we see with human bones. So it's becoming more and more prevalent to be used here in the United States. Now, alloplastic material, that's your glass ceramics, your calcium phosphates. Um, they have their place, right? They're lab made. Uh, they necessitate less um, processing to fabricate. And even though the risk of passing on any viruses like HIV or hepatitis in allogenic bone is extremely, extremely low, right? I think the last number I saw is like one in 8 billion, um, you know, potential for contamination. And, in bovine bone, we're obviously concerned about prion diseases and Creutzfeldt-Jacobs disease with those particular particles. But it's extremely, extremely rare to have any cross contamination. Well, you almost eliminate that with your synthetic bones. Now, you might ask, obviously, if I say, hey, we've got all these different products, well, what's the best? Well, again, I'm always going to turn back to our literature. And what this study from NAPI in 2016 looked at, in this case, 25 samples from patients receiving implants in sites that had ridge preservation or sinus lifts with different types of bone. And at whatever time period they were evaluated, histology, a bone core was taken and histology was performed. And what they found is that allogenic bone tends to be the best in new bone, vital bone formation within that time period. So 65% of that volume was new bone formation, with only about 27% remnant graft material. Now, when you compare that to xenograft, remember I said bovine bone takes a lot longer to break down. Within that same time period, there was only 45% newborn formation and obviously a higher component of remnant graft. Now, with alloplast, it was somewhere in the middle, right? 49% vital bone, 28% remaining graft. Now, the caveat I would say to this is that in other studies, what they show is that the amount of volume you can get is actually least with alloplast. So even though the quality of that bone is slightly better than your bovine or your xenograft material, if you're trying to do ridge augmentation and grow a lot of bone, you're going to be a lot more limited in your success with alloplast than you would be with allograft or xenograft. Now, if we look at this other study by Wood, remember I talked about how if you're using allograft, there's several different variations, and the two major categories are your mineralized and your demineralized bone. Now, let me explain what that is. When you do a bone graft, what's going to happen is, as I mentioned, your body's going to break down that bone graft material that you placed and deposits its own bone, right? So initially, your osteoclasts have to come in and break down that mineralized bone. Well, and that's part of the natural remodeling process. Well, what they found is that if they demineralize that bone, and it typically, involves extra rounds of acid washing and so forth to get rid of some of that mineral content. That means your initial part of that remodeling process happens faster, right? Your osteoclasts have to do less work to break down that demineralized bone because there's less mineral. So if we look at the same time period, it would be intuitive and understandably to say, okay, if we let if we do histology at say 4 months, I think this one was 19 weeks, right? Let's say 4 months. Which one is going to give us the most vital bone percentage? Well, as we would intuitively think and what the data shows, obviously the one where the body can turn it over faster. If the body can remove that bone graft faster, it'll sooner be able to deposit its own vital bone. And we actually see that. Okay, this study here by Wood at 19 weeks, what they found was demineralized bone at that time had 38.42% new vital bone formation compared to mineralized bone only being at 24.63. Now, both of these will be successful, right? Both of these will be successful. In one, you get the added benefit of more vital bone sooner. If you wait long enough, it's all going to average out, but sooner you get more vital bone with the DFDBA. With the FDBA, you get less vital bone, but guess what? Since it's taken longer to break down, you get less shrinkage. You get greater space maintenance. So, being that all we're always trying to do is optimize our materials and our protocols, a lot of companies will now put a mixture, and they would usually do like a 70%, 30% mix of mineralized and demineralized, meaning 70% will be that mineralized bone that's going to hold space for longer, but mixed within that, you're going to have that demineralized bone. So throughout that volume that you're holding now, a fair amount of it, you're going to get faster turnover and faster development of vital bone. And that's really all it is. When it comes to the science of what we're doing, it's not only why we do it, how we do it. Once we know the why and we learn the how, from then what we really focus on is how do we optimize? How do we do what we already know to do better? How do we get our good results even better? Okay. And understanding these concepts is going to help you in your product selection. So that way, you know, as we're fighting for millimeters and, again, millimeters or miles or kilometers when we're talking about the implant world, any little decision we can make that can give us that little bit of edge, that 1 or 2% greater chance of optimal results. It's an easy decision to make because obviously the price on some of these products isn't that different or isn't prohibitive, but it does take you a little bit of critical thinking and knowing this knowledge to be able to drive you optimizing your treatment. So we talked about the different types of graft, right? Autograft, allograft, xenograft, alloplast. We talked about the different types of allograft, right? Mineralized, demineralized. Well, another aspect of grafting that or graft materials you're going to see is the size. You're going to have small particle, you're going to have large particle, you're going to have a mixed particle. And you might ask me, well, you know, which one is better? Why are there options, right? There must be a reason there are options. Well, if we look at this story article from 2013, they did sinus augmentations with small particle and large in small particles in one groups, large particles in other groups. And then when they went back for the implant, they took core bone biopsies and did histology on them. And what they found is that the amount of vascularization and vital bone you get is greater when you have more large particle bones in your graft. And the theory behind that is larger particles are going to allow for greater space in between them. And we know from a lot of other studies that you need at least about 100 microns of space between your particles to be able to form vascularization and actual tissue to grow through it. right? Otherwise, you just have condensed mineral particles that, it's not going to turn into vital bone. Well, the larger your particles, the greater that amount of space. The smaller the particles, the smaller that amount of space. So lo and behold, large particle grafts will give you more vital bone formation than small particle grafts, right? So again, little decisions we're making to just optimize those results. Now, in most cases, if we're going to graft and come back a year later, we're going to see a lot more homogeneity in our results. But for most of us, we're coming back at 3 months, 4 months. In sinus lifts, it might be 6 to 8 months. If you really want to be at the earliest possible window of each step in your sequence of treatment decisions, you're definitely going to want to make sure you're optimizing your material choice to give you the greatest amount of, you know, and in combination of volume, retention, vital bone formation, um, so that way you can have enough, not only enough bone, but the greatest amount of vital bone for your future implant therapies. So, quick summary on bone. Bone is about 65 to 7%, 70% mineral, 30 to 35% organic protein matrix, with most of that being type 1 collagen. Fukuoka in 2003 showed us that if you wait long enough, right? And this one was, they did biopsies at 3 months, 5 to 6 months, 8 to 9 months, 12 to 13 months. In most cases, if you wait long enough, you're going to end up at the same point, right? That bovine bone is going to resorb if you wait long enough. Again, not always going to be waiting a year or more between procedures when we can reliably do some of these, extraction ridge preservation. We can get the implant in at 3 months, right? If we're not doing immediate implants. Well, am I going to put all bovine graft if I'm looking to come in at 3 months? Possibly no. I might choose a mix of mineralized, demineralized allograft. If I'm doing a sinus lift and I'm trying to create a large volume of bone, well, I might mix some allograft and have a larger component of xenograft to hold space, and I'm going to wait longer, right? So as we start fine-tuning these decisions, we can fine-tune the products that we're using. Now there's going to be a slew of products that you're going to see. And this is typically the graphic on the left side, what a classic open membrane technique for ridge preservation is going to look like. We took the tooth out, we put the bone graft material in, we placed a membrane of some sort, and we've secured it underneath the of tissue, and we've secured it with suture. And what I did is listed some of the products that I've used from different companies, so I'm not endorsing one or the other, but these are all products that I've used very, very successfully, right? So Raptos is a 70-30% allograft. Same thing with Maxius. Synergy makes a great bovine product. BioOS by Geislich also makes a great bovine product. So there's a slew of products on the market available for you. So I'm going to pause this real quick and just explain what I'm showing. This is obviously content for a different course, but I did want to introduce, if you're doing bone grafting, one great way to enhance your grafting handling and capabilities is to add platelet products. And platelets are the cells that release a lot of those early growth factors in a wound that's healing. And so if we can concentrate them and reintroduce them into the surgical site, that can always be a plus. And so this is one of my videos of how I create platelet products. And so you indulge me for about 2 minutes here. Let me pause here. Dr. Uvo, are you able to hear the audio in this video, or do I have to share the audio separately?
I did not hear any. I
Okay.
don't. It's not very clear that it's coming out. Yeah.
Okay. Let me see if there's a option to share the audio. So I can hear the audio, but I know with Zoom sometimes you have to share the audio separately. Let me go to more here. Disable, float, record. I'll tell you what, I'll just narrate it because all the audio is me narrating, but I can just narrate it for you here. Um, so what I'm doing here is we drew blood and we collected in these test tubes and we spun it at a specific protocol. And what that spinning did was it collected the platelets and the plasma and separated out the red blood cells. And what we're able to do is remove that platelet-rich plasma that also has some white blood cells, which help in the modulating the immune response and inhibiting bacteria. And we're able to infuse and hydrate our bone graft material with this plasma, which means it's going to be a lot more viscous and easier to handle, which is one of the benefits of it. It's going to be concentrated with almost 20 times as many platelets, which means we're going to get increased amount of positive growth factors released into that healing site. And a lot of these growth factors like VEGF, vascular endothelial growth factor, um, uh, PDGF, so platelet-derived growth factor, are all factors that really help create a vascular bed much faster. And you can see how as it kind of coagulates, now it makes handling very easy. It's no longer loose particles. I can actually pick up nice big chunks and place them and mold them and shape them as I want, whether I'm doing ridge preservation and or ridge augmentation. Okay. So we talked about why we do it. We talked about the bone that we use. Let's talk about membranes. Now, anytime we do a extraction and ridge preservation, what we're doing is we're trying to grow bone where we've removed the tooth, but we're also trying to grow bone before the soft tissue invades. So it becomes this battle of how much bone can we create in this initial healing period, and how much can we minimize soft tissue from growing into that space? And going back to the 80s, we realized that we can actually use membranes to block out that soft tissue. So the membrane isn't just going to be there to hold the bone graft in place. It's actually going to work to keep the epithelial tissue from the coronal part of the superior aspect of your socket from down growing into that space, leaving us with more soft tissue in that bone. Okay. And so what we have found is that, from the early beginnings of membranes, which was our PTFE, which is kind of a Gore-Tex material, if you place that over an extraction socket, what's going to happen is it's going to block out that tissue from invading, and it's going to give you plenty of time for that entire volume to fill in and mature with bone. And in the beginning, we had the synthetic material of the polytetrafluoroethylene or PTFE. Now we've got a slew of biologic materials. And so depending on what you're doing and when, you can still use a PTFE or non-resorbable membrane that you're going to have to take out later. Or you can use a biologic or collagen membrane that'll create a barrier that stays for, anywhere from 3 to 6 months and allows the bone to form and mature. And then it'll eventually degrade out and your soft tissue you know, will still form over the top of it, but it won't invade down into that space. So when you look at your collagen membranes, typically is going to be two types. You're going to be your standard types, which usually resorbs within 2 to 3 months, or you're going to have your cross-linked collagen, which is a preparation of the collagen that makes it more resistant to breakdown. So those will usually last 5 to 6 months. All right. Depending on your case, how much bone you're trying to grow, especially if you're doing ridge augmentation versus preservation, it might drive your decision making in one way or the other. But remember, a lot of these are going to be resorption times in a closed system. If we're doing an open membrane technique, these resorption times might be a little less reliable, in which case I would say always just go with your cross-linked, longer lasting collagen membrane. It's still going to resorb, but because it's exposed to the mouth, your natural pH, your natural enzymes, the foods that you eat, it's going to hold up better than your standard collagen when we do what you'll see as an open membrane technique. Now, if you look at this study by Triano, and this is a 2018 systematic review looking at allograft and xenograft in resorbable membrane to spontaneous healing, right? So whether you're using human bone or bovine bone with the membrane versus not doing any grafting, we can see that across the board, you're going to have much more bone volume retention when you do grafting. Okay. And part of that grafting is using a membrane. If we look at this CUSO study from 2022, looking at unassisted healing versus grafted using a membrane along with your bone graft, 60% of the unassisted healing group, meaning 60% of the teeth where they were removed and no grafting was performed, needed grafting before implants could be placed after healing. Whereas when we did the grafting with the bone and the membrane, that was only about 11%, and the amount of grafting that was needed was also much smaller when preservation was made. So when you look at those numbers, it's kind of a risk assessment, or for any of you that may go to casinos, it's a gambling line, right? If I tell you, hey, if you go this route, there's a 60% chance you're going to need this extra treatment, and we can't go straight to an implant. But if you go this route, it's only going to be an 11% chance. And then the amount of bone grafting I need may be extremely minimal compared to the other route. Okay. So that is how you're developing your rationale. Okay. Doing grafting makes it 17.8 times less likely, or doing ridge preservation with grafting makes it almost 18% times less likely that you're going to need a graft down the road. Okay. Again, preserving bone is much easier than growing bone, and it's very, very predictable. Now, for as we saw in the other study, if you had thicker bone, you need less grafting, right? The consequences of having thicker bone are less. But here's the caveat to that. You don't know how thick that bone is. Most often, we're not doing cone beam CTs to measure the bone just before an extraction, right? Unless we were trying to do an immediate implant. But in most cases, you're working off a two-dimensional um, picture. And a lot of us aren't taking calipers to try and measure that bone. So in general, you're playing the odds. You know that even if there's more than a millimeter, you might get some shrinkage. If there's less than a millimeter, you're going to get a lot of shrinkage. So why not just graft every socket? You're already there. It's not going to add a lot of time to your procedure, and it's only going to benefit the patient, because you can't predict if this patient is going to be, you can't predict with 100% accuracy whether they're going to be someone with thick bone but still get a lot of shrinkage, or someone with thin bone that doesn't get a lot of shrinkage, right? There's outliers in every group. You don't know who's going to be who. So it behooves you to use bone graft and use a membrane. So when we look at membranes, we look at bone preservation augmentation as a race between cell types. We know that Engler showed us in 1966 that epithelial cells migrate at a rate of 0.5 millimeters a day. Okay, now remember, if we got a 10 millimeter socket, if all we were looking at is the ability of tissue to downgrow into that socket, okay, we're going to be 20 days out and you've got epithelium downgrow to the bottom of that socket. We know that bone can take upwards of 4 months, right? But it takes 3 weeks to get early woven bone. So bone is never going to win that race. So our job is to provide the bone graft material, which is going to give the space and the volume for the body to grow bone. And we're going to provide the membrane, which is going to block out all those epithelial cells while at the same time holding that bone graft in place. And now we're creating a safe space for that bone to mature and turn into nice, healthy, vital bone you can place an implant in. All right. So a lot of the membranes that I've used before with great success, when it comes to the non-resorbable membranes, right? Your PTFE membranes, I've used Cytoplast, I've used Cytoflex Tefguard, I've used Salvin Cytosurge, right? So again, A lot of these companies make very similar products, and I try my best to not advocate for any one company in my lectures. Now, if we look at our resorbable membranes, our biologic membranes, we do have several companies again. Salvin makes a great one called Oromem Sustained, which is a long-lasting membrane. Cytogenix makes a great one called Neomem Flex Plus, which again is a 6-month lasting membrane. And Ace Surgical makes RCM6, 6 denoting that the 6-month lasting power. And in this type of case, as you look at this graphic on the left where there's an open membrane that's exposed, having the stronger of the two resorbable biologic membranes when it's exposed to the mouth is going to give you greater security that it's not going to be resorbed much faster by natural pH and your enzymes causing hydrolysis and so forth. Now, this is one of my favorite parts, suturing. Okay, I put a lot of suture workshops for both pre-health students and doctors. And I can't tell this part without giving you some history because I think it's important that we realize that what we know from what we consider modern medicine tends to be very Eurocentric, but a lot of stuff that we do is based on principles and strategies that predate European and Western textbooks. So if we look at suturing as an intervention meant to hold body tissues together, is reported in written form as far back as Egypt in 3000 BC. It was observed in mummies at 1100 BC. 500 BC, very detailed description by Sushrata in India, known as the father of plastic surgery. If you're a nerd like me, look up Sushrata and some of the surgeries that he was doing back then, some of the pedicle flaps from forehead to nose, just tremendous surgery. And we also see some of this stuff back in the Mediterranean from Sus in Rome and Hippocrates in Greece. Initially, they were using bone, silver, copper, and bronze for the needles. The early sutures were made of plants like hemp, flax, or animal or body parts like tendons or muscle. The Edwin Smith papers, which clearly that's not what they're originally called, but a European discovered these and gave him his own name, right? As we know, happens a lot. But it's one of the oldest surgical texts that we know of civilization and is currently at the New York Metropolitan Museum. But it mentions almost 50 times the use of the detailed use of sutures on this papyrus. And one of the examples, and I guess it's translated into Old English or Shakespearean English. If thou findest a wound open and its stitching loose, thou shouldst draw together for him the gash with 2 strips of linen, right? So the concepts of surgery, the concepts of healing predate Western medicine for sure. Now, in other parts of the world, we look at amazing, amazing contributors to the stuff that we do today. So Rhazes in 8th century Baghdad pioneered the use of horsehair instead of just catgut for sutures, especially for abdominal wall repairs. Ali ibn Sina in the 10th century, in what's present day Persia or Iran. He wrote the Canon of Medicine, describing the use of different techniques with sutures, optimizing the types of knots you can use to avoid any weak spots. And we had Al-Zahrawi at the same time from the Western Caliphate that produced detailed works describing cautery and how to stop bleeding using sutures. Now, if we look at other parts of, let's say, Eastern Africa coming out of Ghana, tremendous story here where at the time in Europe, C-sections were done as an emergency only treatment with the understanding that the mother would die and they would only be able to save the baby. But it was a routine practice that had been perfected for its time in parts of Uganda with extremely high success rates of not only saving the baby during a difficult delivery, but also saving the mother. This was back in the 1800s. And what they used was a mbugu bark cloth for the suturing material and iron pins for the needle, right? So there's a rich, rich history beyond the Western world that I always have to mention when we talk about this stuff. But in suturing especially, it's kind of become my soapbox moment. Now, back to, why we're doing what we're doing when we're suturing. Well, we know that there's two main layers to the oral mucosa. There's the oral epithelium and there's the lamina propria, right? The connective tissue layer. Now, the oral epithelium is usually stratified squamous, but it can also have a layer of keratin. And the lamina propria, again, it's connective tissue that's rich in collagen, has vasculature, nerves, adipose tissue, and a lot of our migrating cells. The healing phase of soft tissue is very similar to what we saw with bone. There's hemostasis, right? We get a blood clot that forms, initial inflammation, we get infiltration of all these early immune cells that are breaking down necrotic tissue, killing, phagocytizing foreign material and or foreign, microbes. By days 5 to 9, we start having some rebuilding of the tissue. So the fibroblasts are coming in and they're laying down that early collagen. And then after that, we get a series of maturation and remodeling, which in its attempt to rebuild or regenerate what was naturally there. Now, most trauma in the oral cavity for soft tissue, we say about 6 weeks is your general healing time. And we see that across the board, whether you're doing bone grafting, whether you're doing soft tissue surgery like gingival grafts, 6 weeks is what we really consider that prime healing time for soft tissue. Now, again, regeneration versus repair. If we can bring the tissues back to approximate what they should be, right? We're bringing epithelium to epithelium, lamina propria to lamina propria. The chances of us getting a scar when we do primary intention is minimal to none, right? And this graphic shows a very minimal scar. Well, if we make a incision or there's surgical trauma and we don't approximate tissues, then we get what's called secondary intention healing, which often leads to a scar formation, right? Because we get this epithelium that fills in and bridges the gap between the two sites that should have been brought together. Now, there's many different suturing types. In the same way, there's many bone graft types, there's many membrane types. There is an insurmountable amount of different types of sutures. So we got everything from cat gut, right, from the internal intestines of animals. We have silk, polypropylene, um, PGCl or PLA, polyglycolic acid, and some of their derivatives. What I'm going to say is whatever your choice is, and I don't need you to read this whole slide. If we make our slides available, you'll have it for reference. But the gist of this slide is there's a lot of studies, like the Serrano study, that looked at which um, sutures hold better and which ones collect less plaque, right? Less bacteria, because you also want to keep this site as clean as possible, as minimal bacterial colonization. We know we already have 700 species of bacteria in the mouth, if not more. We want to make sure in that particular site, we're not creating a bed for bacterial colony and potentially very pathogenic ones to be able to grow. And your braided sutures, like your silk or your vicryl, right? And here you can see in the lower picture, square A is silk, and you see it's very braided, and you can see a lot more buildup on it. B on the right hand side is Vicryl. It's a great product, but it's also braided, so you tend to see a lot more buildup, or you see a greater film of bacteria on it. Whereas on the lower ones, right, your polyamide, your PTFE, they're monofilament, so they're not braided. So they don't retain bacteria as much. And you can see here in this study, they found that on the silk, 54% of the surface area was colonized by bacteria, whereas on the other monofilament sutures, it was only about 22%. So that should guide some of your choice making on what type of sutures to use. Here's another study by Leknes in 2005 doing histology in sites that had sutures. And basically what they found is that silk sutures, which are braided, compared to PTFE, which is monofilament, so non-braided, at 7 days, silk showed higher degree of slack, meaning it lost some of its holding power, but also had a much greater amount of bacterial colonization and induction of inflammation. Okay, so if you look at the picture on the bottom, which is the silk, and you see all these cells around it, there's a lot more inflammatory infiltrate around these braided sutures because they have a higher bacterial colonization than the monofilaments do. So whether you're using an absorbable suture or non-absorbable, I would please implore you that you choose one that's a monofilament and that's not braided. So again, some of the products that I've used that work great. Unify makes a great PTFE suture. Glycolon is an absorbable suture. This Unify PGCL is another absorbable suture, but they're all monofilament. Different companies, but they're all different types of monofilaments. Some that you have to remove, other ones that will dissolve. Now, you might ask me, what's the difference between, let's say, a chromic gut, which is monofilament and is resorbable, and a glycolon or a PGCL? It's staying power. Chromic gut is probably going to last you about 7 days. And we know typically we want at least about 3 weeks of holding power for some of our periodontal surgeries and grafting surgeries. And your PGCLs and glycolons are going to last you about 21 to 25 days before they start to resorb and lose some of their power. So that's a little bit more pricey, but absolutely worth what you're going to be using them for. Okay, so I've inundated you with the how or the why and the what to use. Now let's talk about how. And I'll quickly go through some extraction strategies before I show you some of my own cases. Now, you're going to hear the term atraumatic tooth extractions pretty regularly. And it's a buzz term that came out a decade or two ago. What we really mean by atraumatic is minimal traumatic. Taking a tooth out is going to be traumatic. In cases where I've had doctors that took atraumatic tooth extraction courses, they often paint it as you should never take out a handpiece, never remove any bone, never cut the tooth because that's traumatic. Well, what ends up happening is they're elevating on that tooth for an hour to try and get it out without removing bone. And that's traumatic to the patient, right? You're causing psychological trauma by those old stories we hear of, oh, the dentist put their knee on my chest and they were pulling, right? That's where you hear those. My definition is, how can you be efficient to take the tooth out, whether it's surgical or non-surgical, with as little possible disruption to the hard and soft tissues and their relationships to each other, while minimizing the psychological effect to the patient. And the way you're going to be able to strategize and plan this is you're going to look at your radiographic assessment. You're going to look at, is there existing infection? What's the shape of the root? What's the volume of the bone? Is there a root canal status? Is this tooth fractured or brittle? Are there any pre-existing cracks? Now, if we look at, and these are right here, I think are images from, some of them are images from the Mish textbook. In general, you're going to want to do an incision, a sulcular incision to release the connective tissue attachment to the tooth. You're going to use either periotomes to start to loosen the tooth and disconnect it from the periodontal ligament. And then you can use your forceps with either buccolingual or rotational force to get the tooth out. If it doesn't come out easily, and in general, most of my anterior teeth will come out relatively easy, as will my premolars. But if they're fractured or just for whatever reason a tooth is giving you a lot of resistance, I'm a big fan of sectioning. So these pictures on the left here are from the Mish textbook, where they recommend sectioning the tooth buccolingual. I'm more of a fan of sectioning the tooth mesial to distal. So the pictures on the right is my case. The reason I do this is because part of this sectioning is blind. If I go a little too far to the buccal on this left side, I might drill through that buccal bone. Whereas if I'm going mesial or distal, if I go a little too far, I have a fair amount of interradicular bone that if I remove a little bit, it's not going to harm anything because my buccal and lingual plates determine, that final potential bone volume. So what I'll do is, especially in the anterior, I'm almost always sectioning mesial to distal on a tooth that needs sectioning. And you can see here these incisions, sulcular incision lines, sectioning of the tooth. and you can see evidence of my sectioning in that bottom picture. Now on the lower, same thing. I'm a big fan of sectioning, so I'll do circular incisions on the buccal and the lingual. I'll just release the tissue just a little bit. I'm not laying a big flap yet. If I need to, I will. I just want to be able to visualize a little better. In most cases, will cut the crown off, right? So that's a surgical extraction, but I'm not removing any bone at that point. I'm just cutting through the just underneath the margin of the crown and popping the coronal portion off. But then here, as you can see, let me go back here. On the lower left, I'll remove bone intraradicularly. So remember, as long as I'm not touching that buccal and lingual plates, removing bone either in between roots on molars or in between the teeth is fair game. Because again, my buccal and lingual plates will dictate the height and the amount of volume I can retain. So why not make this a 5-minute extraction versus a 1-hour extraction by strategic removal of bone, right? I'm removing bone that's not going to affect my final volume whatsoever, but it is allowing me to get instruments in and position them in an appropriate place to be able to remove these teeth in a fast, efficient manner. Now, if you have, let me play this video here. You can use these vertical extractors. Let's say if you really, really, really want to be conservative, we use this as part of my master's clinical research project to standardize the extraction process as we were comparing different forms of material in similar bone grafting techniques. So here you make an access to the pulpal area just as if you were doing say a root canal. You put in an internal screw, which engages the screw from the inside. And then there's a pulley system that you attach. And as you turn it, you can see here, it pulls the tooth out. And it's a way of creating minimal trauma. So I'm not removing bone. I'm not, potentially damaging a thin buccal plate. And there you go. Now, as far as pharmacological considerations go, in general, in a healthy patient, your incidence of infection, even when you're putting foreign material in, is low. Okay. This study from Powell showed that it was about 2%. Most people, though, will, because we know there's good data on prophylactic antibiotics for implants, we transfer that knowledge to bone grafts. If you've got a very healthy patient and you're doing a very small socket, small amount of foreign material, in general, you don't absolutely need antibiotics, but you never know who's going to react how. And so in most cases, I think there's enough information in the literature to justify at minimum your prophylactic antibiotics, right? So 2 grams of amoxicillin before your surgery, 600 milligrams of clindamycin, 500 milligrams of azithromycin, or whatever the choice is, depending on the patient's allergies. Now, other people will also, and I'm in that group, will also give antibiotics for at least 3 to 5 days afterwards, right? So I'll usually do amoxicillin 875 twice a day for 5 days after surgery. Now, if there was a pre-existing infection, if the patient is prone to infections after surgeries, I might be more aggressive. So I still try to tailor it specific to the patient presentation. All right, so you're probably tired of me throwing science and all that at you. Let me do some case presentation really quick, and then we'll do some Q&A, and I'll leave you back to your Sunday. So here we have a fractured tooth. Very common presentation. Looks like someone actually had a perforation when they were doing the root canal. Again, as I've said, I strategically like to remove bone so I can get the teeth out in a fashion that's fast and efficient. And when you look at this afterwards, I still got my buccal and lingual plates. I use my platelet products, but there's my bone graft material. And in this case, we use a non-resorbable membrane. I pouch or make slight full thickness reflections in the buccal and lingual so I can tuck that membrane just a few millimeters underneath the soft tissue, so it has some mechanical retention. In this case, sometimes I'll add a PRF membrane to help protect it and add some of those extra platelet factors. We'll tuck the membrane under the opposing side and we'll secure it with sutures. So you'll see in this case, the PTFE membrane that we talked about, bone graft that we talked about, and the PTFE sutures. You see these are monofilament sutures. With the non-resorbable membranes, we usually take them out at around 6 weeks. It doesn't require a separate surgery. You'll see here from this video to take it out because it's going to stay nice and open. Remember, it's blocking out the epithelium. Epithelium is not going to grow over it. All you got to do, you don't even have to anesthetize the patient. You're just going to grab it and you're going to tell them that it's going to feel a little weird, going to feel a little bit of pressure, and it actually can disconnect it from the overlying tissue. And just pull it, and it comes right out. Okay, and then that raw connective tissue underneath is just going to form a keratinized layer and come out nice and beautiful like this. So now we're able to plan our implant. We got nice keratinized tissue because we didn't do a full thickness flap. And you can see how we got a nice implant placed in a restoratively driven position. One of the things that I love about photography is I can zoom in, and although before it may not have looked as obvious, by I zoom in, I see quite a bit of plaque buildup. So then I always get in the habit of deplaquing your patients every time you see them in a surgical site, remove some of that plaque, and then give them the tools to be able to keep that area nice and clean so we can minimize inflammation long term and provide them with a very successful long-term implant therapy. Now, that was a posterior case. Here's a slightly nuanced one. Patient with history of periodontal disease. We've got them stable in the periodontal health here, but we got a tooth that had an infection. It's non-savable, and there was actually a fenestration or a window on the inside of that buccal plate. So in those cases, what I'll do is very conservatively, I'll get the tooth out, but I'll do what's called an ice cream cone technique. Well, I will cut the membrane as so, kind of looks like an ice cream cone. And what I'll do is I'll tuck it in and press it up against that buccal plate, but it's internal, it's not external, right? I'm not reflecting any flaps or pouches. But what I'm doing is I'm covering that window that was down here. I don't know if you can see my cursor, but there was a window where you could see the soft tissue. I've covered it. I put my bone graft material, I tuck it gently over that or underneath that free gingival margin on the palatal. And I'm sure your eyes are darting. We absolutely saw this bit of decay here, and you'll see that that's actually taken care of. But this is a monofilament resorbable suture. Okay, it's I believe it was a glycolon suture. Great, great product. So here, this is the post-op. You can see we've taken care of that caries, but look at how much bone we've preserved. It is so easy now to put in an implant because we've preserved that entire ridge structure. And this is the contours you can see from the occlusal view. So here we do our implant placement. This is our day of surgery, right? It was very conservative. Healing a few weeks later. And now we've got our implant in place. And I believe this is the 1-year follow-up on that implant. Okay, great bone levels, great soft tissue levels. All because I did my best to set myself up from success before we got to the implant. The best thing you could do for you and your patient is prepare the site ahead of time. And ridge preservation is one of the best ways we have to do that. So that way, when we come back for that implant, it's all good, healthy, more than enough or adequate native bone that you're working with. You got your native soft tissues that are usually preserved with this type of preservation technique. And it makes it so that each time you're doing a surgery, you're only performing one miracle at a time. I did that miracle of preserving bone. Now, the miracle of attaching titanium is easy. I'm not having to go back and do a separate miracle of growing even more bone, right? Outside of its natural housing, only to then put an implant in. So I'm hedging my bets here. I'm setting up each particular stage to be its maximally or as maximally successful as possible. With that being said, I thank you for your time and your attention. I know I took a little bit more than an hour, so I do apologize about that. But I would love to field any questions that you all may have from this lecture.
All right. Thank you so much for that lecture, sir. We do have some questions. Dr. Oni, are you there? You had a question on there. If you can read out your question. If another person had a question, just raise your hand. Just lift your hand using your raise your hand thing there, and I will pass the microphone over to you to speak. All right, go ahead.
Okay, thank you. Thank you so much, sir. Thank you for the insightful lecture. I have a question. I'd like to know if we can place immediate implants after extractions for molars. And if we can, how many implants are we going to place? Since the molars are multi-rooted, which of the sockets are we going to place the implants? Are we going to be placing 2 implants or just 1 in a specified socket? That's my question. Thank you so much.
Yes, great question. So yeah, we can absolutely do immediate implants if the situation allows for it. So typically, when you have your cone beam, see if you're considering an immediate implant, you're always going to want to have a cone beam ahead of time, so you can see how much bone there is beyond the apex of the tooth, how thick your buccal and lingual plates are, and what the best angulation to put that implant is. And it's a little bit more advanced, so you have to be very cognizant of being more precise with your implant placement, and be very astute with your grafting principles and soft tissue management. Typically, it's going to be 1 implant per tooth. And in most cases, where you're going to be aiming that implant is going to be in the interradicular bone. So if here is your molar and it's got 2 roots, your implant is going to be in that bone in between the 2 roots. If it's a upper molar, right? What most times you're going to be aiming for is that interradicular bone in between those roots. But yeah, you can definitely do immediate implants. You just have to know how to do it, what the grafting protocols around it, and what are the best scenarios to do so, and then when to abort that. Sometimes you might be planning an immediate implant, but when you get in there, either the bone is soft, you're not able to get adequate primary stability, or there might be some other complications, and you might have to go back to your traditional ridge preservation. But yeah, immediate implants, I would say if you're starting to do implants, get at least, 30 to 50 implants placed in a traditional staged way that you've at least seen through and followed through to make sure that they healed properly, to give you that confidence that you really know what you're doing. And then start adding immediate implants to your repertoire.
All right,
Okay,
thank you.
Thank you so much.
All right, so we do have Dr. Gave. Go ahead, Edinam.
Yes, thank you, Dr. Morton. Thank you. Very grateful for your presentation. With your slide on the definitions of regeneration versus repair in bone, I'm assuming we want regeneration. Is regeneration and bone regeneration and bone repair exclusive events or processes? Can repair sometimes lead to bone regeneration? And then how do you know that the healing process is going to lead to?
Yeah, great question. Regeneration is more of a very defined concept and definition when it comes to periodontal surgery, right? So regenerating the cementum, the periodontal ligament, and the bone. Very, very specific. If you're missing any one of those, you didn't have quote unquote regeneration.
What do you do? Do you digitally compress the socket? Do you pack? Do you what do you do to set the path for bone regeneration? Thank you.
Yes, thank you. I think you cut out a little bit. I think I got the gist of the question. for bone regeneration in an extraction socket, it really alludes to maintaining the original dimensions, right? So it's sometimes it could be a game of semantics on whether you got regeneration of repair, right? If I was able to maintain 100% of the original volume, we usually call that regeneration. If I only retained 50% of that original volume because I didn't do bone grafting, we call that repair, right? It just healed smaller. Now, some might argue, well, what if you're at 90% of you did graft, but you got a little bit of shrinkage? In general, as long as you're extremely close to what your original proportions are, we just call that regeneration in the world of socket preservation, right? Maintain close to, if not equal to the original bone volume. Now, how you do that is you measure it, right? How you define that. So when I go back and I do my cone beam, or when I look visually, do I see the original contours, right? Do the contours match the contours on the teeth on either side of this edentulous space? If we're really close to that, then we tend to term that in as regeneration. As far as manipulating the socket with our fingers, that's it's an old strategy that people used to use when you take a tooth out and you're not doing any grafting, because if you can collapse that socket, that's a smaller blood clot that has to form. It's less exposed to the environment, and the theory was we're protecting the site by making it smaller. Well, in a day and age now that we're trying to actually preserve that greater volume, we've gotten away from trying to digitally, compress and squeeze that socket. We're just trying to protect it, right? So regardless of whether we do grafting or not, we want to make sure that the patient is adhering to their post-surgical instructions, that we are at least securing the tissue so the tissue is not flapping around, and that we're removing the tooth with minimal trauma as possible. But in general, what you're aiming for is what we would perceive as regeneration, which you'll hear those terms. I just like framing it in the context of, did you keep as much volume as possible? Are you as close to the original volume as possible? Then you were successful. If it shrunk because you didn't graft it, we knew that was going to happen. If you grafted it and it shrunk, then we might have to revisit some of your surgical protocols. But in general, with sound principles, if you're grafting it, you're going to maintain, 85+% of that original volume, and almost always that's more than enough for implant placement. Good question, though.
All right, Dr. Oduola, go ahead.
Thank you so much, Prof, for the very insightful lecture. I just have a few questions. You mentioned open membrane technique. I don't have an idea of what that is. I'll appreciate if you can explain. Then also, when you are when you're using membrane after ridge augmentation, after using a bone graft, and you use a membrane, I know some people have said that you can have a separate suture for the membrane. I don't know, but my question really about that is, what is the implication of penetrating or perforating the membrane in case you don't have a separate suture for it? What's the implication of penetrating the membrane while suturing? Does it have any implication in the amount of the bone volume that is formed at the end of the day? Thank you very much.
And I do apologize. The mic was a little cloudy. So you're asking did you say if there's a separate code for the membrane?
You said if you when you were suturing and you made a hole in the membrane,
can you go through the membrane when you're suturing? Yes. Great question. Absolutely. So what I would say, your open membrane technique is really just means that you're not laying a flap and pulling it over to close that entire space with soft tissue, right? Because when you do that, you're taking that keratinized tissue and you're pulling it way over and it's usually you're pulling it to the lingual or the palatal, and now the buccal aspect of that membrane is going to be all that mucosal, less resilient tissue. So the open membrane technique means your flap This is my buccal flap. I'm not going to stretch it here. I'm just going to leave it like this, and this membrane is going to bridge that gap. Now, when you're suturing, yes, you can absolutely actually suture through the membrane and then through the tissue, and it'll help secure the membrane. Whether you're using a collagen membrane or non-resorbable membrane, you can absolutely puncture the membrane. What I would do is be very strategic in how you're guiding your needles, because if this is my socket, if I'm taking my needle from the outside in and I grab that membrane, you're going to see the membrane bunch up and push out. So if I'm looking to secure the membrane, what I'm going to do is I'm going to go from the inside of the socket, grab the membrane, go through the inside of the tissue, and then come out. That way, as I'm engaging the membrane, it's only pulling it down into, you know, that underneath part of the soft tissue flap. So it's securing it in place. So you can absolutely go through the membrane. Just make sure you're strategic in your suturing. And my best recommendation is go from the inside, go through the membrane, come out the soft tissue. That way it's locking the membrane to the soft tissue. If you go the other way, as you're pushing your needle up, it's going to push the membrane and bunch it up out of where you ideally want it.
Okay.
Thank you very much.
Thank you.
All right. Dr. Satimei, go ahead.
Yes, sir. Good evening, everyone. Thank you very much, sir, for the lecture. So my question is about patients usually that they've had maybe extraction done maybe years ago, and due to the functional disability of not being able to masticate properly, they decided to come back for an implant. And we know that already that site would have healed, the resorption of bone would have happened already. How do we manage patients like that? Do we have to recreate how do I say it? Recreate a wound in the bone and do a new grafting, bone graft there? How do we go around that situation? Then my second question is that has there been situations where patients have should I say a graft rejection? Since the materials that are placed there sometimes are from animals, are there been situations where there was rejection of the graft? So those are my two questions. Thank you.
Great question. Yes. So if someone comes to you and they've already had their bone resorption, right? So they have a deficient site that's shrunk over time, then you have to do what's called guided bone regeneration, where you're essentially reflecting a flap to expose that defect. You're decorticating the bone, so you're creating puncture wounds in the bone so you can get good bleeding from that medullary blood supply. Then you're adding the bone graft external to that. And maybe, Dr. Uva will bring me back. I have a great presentation on guided bone regeneration that goes over the principles of how to grow bone after it's already shrunk. Now, it's predictable in and of itself, right? We have great success with what's called guided bone regeneration to rebuild those sites. It is more technique sensitive, and as predictable as it is, it's not as predictable as ridge preservation. Ridge preservation by far is going to be much more. So that's why I always say, if we got to choose which miracle we're going to do, let's choose the easy one. But we often get patients that had stuff done somewhere else, and now we're seeing them, and this is how they present. So yeah, there's almost always still options for those patients, but it's a whole different protocol of bone grafting that we do. Yeah, and I would love to come back, and I've got some great cases and kind of science describing the flap designs, the bone manipulation, the grafting materials, the adjuncts that we use to pull that off very successfully. And as far as the graft rejection, I would hesitate to call it graft rejection per se, because these materials are for the most part very inert. They maybe elicit a small amount of inflammation, more so than just a generic surgical wound would. But we do have we do have a small amount of patients that just get an infection at the time of surgery or shortly thereafter. And typically that can happen even if you're not adding any foreign material, right? You can get an infection from just an extraction. You can get an infection from a soft tissue surgery. A lot of times that's a factor of the patient's natural biology. Are they immunocompromised or uncontrolled diabetes? They have some systemic factor that's contributing or making them more prone to developing infections. Sometimes it's your surgical technique, right? When you were removing bone, did you not have adequate irrigation and you overheated the bone and the bone became necrotic when you were taking the tooth out? And then that could turn into a subsequent infection. Are they on any medications, right? If they're on immunomodulatory medications like monoclonal antibody therapies, are they on bisphosphonates for osteoporosis? There's a slew of reasons. We try to mitigate those by obviously doing a very good health history, by having very good sound surgical strategies and protocols, by giving at minimum a prophylactic antibiotic, right, an hour before surgery. And most of us will also give a post-operative antibiotic for anywhere 5 to 7 days. So we try to minimize that. But even then, sometimes you do everything perfectly right, and you'll have that 1% of your patients that still develop an infection. But I wouldn't necessarily call it a rejection per se. It's more of a general infection, because again, the mouth has over 700 species of bacteria, and everyone has a different ecosystem in their mouth. And so some people are always going to be more prone to infection because they carry more pathogenic bacteria, or their immune system is sometimes more deficient than other people. But again, in that Powell study that I quoted, periodontal infections in our surgeries, it's less than 2%, as long as you're doing everything correctly. And if you do get one, don't always analyze what you may have done or could have done different, but don't feel bad on yourself, because if you do enough of these cases, you are going to get those patients where you did everything right, but you still got an infection, because biology can be unpredictable. But great question. I would love to come back and do a guided bone regeneration, right? So it's grafting after it's already shrunk and healed. What do you do then? I've got some great content on that. I'd love to come back and talk to you guys
Okay,
about.
yeah, we'll arrange for you to come back. I know you have your schedule is kind of booked, but we'll see how to get you back as soon as possible. Quick question. They have two more questions, and there's one that's written down there. Dr. Macharia, are you there? Macharia from Kenya. Dr. Macharia, if you can hear me, go ahead.
Good evening. Thank you, Prof, for the wonderful lecture. My question is on alloplast. Recently, some peers have started advocating more of the hydroxyapatite and calcium derived alloplasts for grafting and sinus lifts. What's your experience with such products like Ethos?
Great question. Alloplasts, like I said earlier, they're a good product. If you're doing ridge preservation, as long as you do it, all your protocols are pretty sound. I can't tell you per se that any one product's going to be better than the other. So alloplast is definitely a decent option for ridge preservation, because you have your walls entailed, right? You already have your buccal plate and lingual plate. And so the miracle you're trying to perform already has its boundaries by the natural bone. Okay. If you're doing your larger surgeries, like your larger sinus augmentations or your larger guided bone regenerations, where you're creating new boundaries, and these boundaries are largely supported by that material that you're adding in, alloplast seems to perform less, right? Now, if I'm doing a large sinus lift and I use alloplast material and I raise the sinus 15 millimeters, and let's say with xenograft and allograft, I'm able to raise it 15 millimeters and it stays 14 or 15 millimeters when it's healed. Versus if I use alloplast and I raise it 15 millimeters and it shrinks down to 11 or 12 millimeters, right? There's a difference there. But if all I'm going to do is place a 10 millimeter implant, that difference may not be consequential, right? because I don't know how much any one person is going to shrink or respond. I try to use the materials that statistically give me the best results, especially when I'm trying to create new boundaries. So sinus augmentation and guided bone regeneration, where I'm trying to augment a already deficient ridge. In those cases, I will shy away from alloplast, but I've used alloplast, and in socket preservation, they usually work just fine. Again, because your natural biology is creating those outer boundaries. What you're looking for is something to hold space and to provide a scaffold. And in those cases, I think alloplast is tried and tested. But I think the literature is pretty sound that if you're trying to grow de novo bone, like a guided, you got a site that's already shrunk and now you're trying to augment it, alloplast is probably going to give you slightly less volume results than you will get with allograft or xenograft.
All right. Thank you, sir. Dr. John Oka, are you there? You asked a question. Dr. Oka, can you hear me? Anyway.
Yes, I can hear you.
Okay, go ahead. You had a question about...
Yes, I wanted to know if how we can actually assess the bone density clinically without recourse to the use of maybe CT scan or CBCT. In other words, what I mean is how we can determine a bone density clinically when a patient comes to the clinic.
Okay, I think you're talking to an old soldier. He has been there and done that. Okay, go ahead, sir.
Yeah, it's with two-dimensional x-rays, it's really hard. You can kind of play the statistical game and say, if I have a much older female patient, especially, density is probably going to be lower, right? There might be some history of osteopenia, osteoporosis. We know that depending on your demographics, patients of color, right? So your South American, Hispanic patients, your African patients are going to have slightly more bone density than your European patients. So you can maybe use that to guide some of where your initial thoughts or intuition is going to be going. Even with CBCT, using the software to measure the Hounsfield units, it's not 100% accurate. Your most accurate determination of density is going to be your tactile sense. So when you get in there and you're, elevating that tooth, you're putting forcep motion on it, you'll be able to get a sense of the bone density better than any other time, right? When you're placing an implant, there's times where I've had sites that the Hounsfield units on the CBCT seemed like they were really low, so I anticipated really soft bone. But when I got in there, there was pretty hefty resistance to my drill, and the implant engaged really, really tightly. So you are probably the best arbiter of determining that bone density. As far as bone thickness, like if we're talking about like the thickness of the buccal plate, so you can decide whether or not you want to graft or not. In those cases, three-dimensional imagery can help. Use of calipers can help. I would argue if you're already extracting the tooth, because even within those measurements, they're all statistical averages. So even within people with 2 millimeters of buccal plate, there's going to be the outliers that still have a lot of shrinkage without grafting. So I would just say graft everybody, right? And then in determining your bone density, give it a proper healing time before you place an implant. You can get some idea from the cone beam, but your hand is going to be the best measurement of bone density.
So this question is involved with the planning. So you're trying to plan a case. So what do you do once you don't have a CBCT?
A case for an implant or a case for an extraction?
No, for an implant.
Yeah, again, if you don't have CBCT is going to be is going to give you the vast majority of your information for proper implant planning. when you don't have a CBCT, and I'm from the era where we did what's called a poor man CT, where we took a model, impression, made a stone model, we anesthetized the gums, and we bone sounded, all across the center of the ridge, and then we cut the model right in the middle of the edentulous site, and we transferred those measurements to draw a line internally, and we can kind of see the outline of the bone. And in molars, I mean, if you're experienced enough, you can predictably place an implant successfully that way, with no surgical guide and no cone beam. But there's no way to really tell bone density per se. The closest you could probably get is, let's say, for whatever reason, an extraction was done and you got nothing but soft tissue ingrowth. That'll be very, very clear, right? Because there'll be no radiopacy at all. It'll be all radiolucent in that two-dimensional X-ray. But if you have a two-dimensional X-ray, it's really hard to tell bone density, because there's times where the trabeculations on that are very loose, but you get in there and it's still firm bone. So I don't know if I have a great answer of how to determine bone density ahead of time. You can determine bone volume as I described with the cast model technique, but without a three-dimensional X-ray, it's really hard to get a accurate, volume and density reading.
All right. Last question here. There's someone that left with anonymous questions. He said, have you had any complications with allografts or xenografts? And is there a place for the use of antibiotic beads in sockets post-extraction?
That is a great question. So I wish I could pull the name of this study. Back in the day, we used to add tetracycline or amoxicillin. You would get the little capsules, and you would cut the capsules or break the capsules and add that into your bone graft material, right? And the theory was that with that physical presence of the antibiotic there, you're diminishing the possibility of getting a infection. The data shows that in general, your infection rates are low, especially even if you're doing like something to sinus. Sinus grafting is one of the most predictable procedures that we do, as long as you know how to do it right. But there's no added benefit of actually giving a physical antibiotic into or mixing it with the graft material. So all the data shows that systemic antibiotics, and essentially the antibiotic is going to get washed out, metabolized, and enter into the bloodstream, even if you give it in that route. The potential complications that you're maybe adding is the if the pH of that antibiotic is low, you could potentially break down that bone graft material. Tetracycline, for example, has a lower pH than what's the physiologic pH. So you're potentially adding an acid to an area that's going to help break down that bone faster, which may or may not be what you want to do, right? So I would say, trust a systemic antibiotic, and I don't really find a need for adding antibiotic spheres to your surgical site.
All right, thank you so much. I'm going to pull you. Anytime we see you, we have lots of questions. Anyway, I'm just going to show something here before we let you go. Just 1 second here.
Yeah, you can also oh yeah, there we go.
So this is a patient case that is coming up, and so they're wondering, okay, what do we do? It from the looks. So how do you now determine they don't have CBCT? So they've taken a cast. So how do you determine in terms of planning a case? You need to find the diameter, you need to find the length. How do you go in a low resource setting where this gentleman is trying to do this case? Patient is motivated. What are the issues you see here, and how would you tackle it?
Great question. So if we don't have cone beam, I would definitely urge that technique that I mentioned, where you got a stone cast like that, anesthetize the patient and bone sound down the center. And you're going to go from the vestibule in the front, and every 3 millimeters, take a reading, puncture the gums down to the bone and measure the depth. And you do it all the way across the crest and up the palate, right? And then you can sketch that. You get your readings. Then what you're going to do is you're going to take a duplicate of this cast and you're going to cut it right down the center. And you're going to turn to the cross section and you're going to transfer those dots at those depths. And now you can draw a line and connect them, and you can get an idea of, how wide and what angle that bone is. Because remember, it's not just how wide the bone is, is that width uniform? And in the anterior, we tend to see it's very wide at the base, and then it gets thinner at the crest. And so you're going to want to know, is that width uniform? Is there a buccal concavity where it's really shrunk in? Obviously CBCT is the gold standard for planning, but that'd probably be your best bet. And then that way you can choose, the width, you can choose your appropriate diameter and length of implant. What I would also urge is do what's called a diagnostic wax up, where you get a wax representation of the final restoration. Because that's going to give you a couple things. It's going to tell you where mesiodistally and buccolingually you would ideally want to be for your restoration. And you can match that up to where the bone is and try and make the best possible compromise between your restorative angle and where the actual bone is. It'll also give you any potential limitations on the restoration, right? Like this restorative space looks a little big. So I would ask the patient, did they have a natural diastema that they want to reproduce in the final product? And depending where you're at, here in the United States, my daughter and a lot of my wife's family, they have a natural diastema in the middle, which I thought is beautiful, but my daughter wanted to close that gap, right? But we know, especially in a lot of regions in West Africa, that's a sign of exotic beauty. And so a lot of patients that I've treated that had a natural diastema in the middle want to reproduce that, which means we'll do the diagnostic wax up, and now I can plan that implant to be slightly distal of center. So that way it's in the center of my restoration, but my restoration is not necessarily in the center of this edentulous site, right? And it almost looks like this restorative space is slightly bigger than this tooth. So my guess is, even when I look at the thickness of that papilla or that tissue on the mesial, it looks like there might have been potentially a natural diastema somewhere in there that we either have to reproduce, or the patient knows that if we completely fill that space, it's going to be a much larger tooth on one side. Oh, look at you. Magic touch there, right? Or are you going to do restorations across, canine to canine to try and average out that space? But I would say if this patient had a diastema beforehand, plan accordingly that you were going to reproduce that. That way your implant can be centered to your restoration, and you're not trying to objectively put the implant in the center of the space, which will make it a little off axis from your ideal restoration.
All right. Thank you so much, my brother. I think, I have this feeling that we're going to be in Nigeria running a live class, and you guys are going to pay a lot of money. They have to pay a lot of money so that we can buy some tickets. That's all we need. We need tickets and a nice place to stay, and we'll be in Lagos. If you can make that happen, reach out to me. But thank you so much for giving us your Father's Day, for being here on Father's Day, where everybody is like, just chilling for the day. But thank you so much. We truly appreciate this kind gesture. And obviously, we are going to have you back for tissue regeneration and more. Thank you, sir.
Yes, sir. And happy Father's Day to all the fathers out here. And it was an honor being able to talk to you today.
All right, then. You take care now.
Bye-bye. All right. Take care.
All right. The class is over. Any questions? This is Nawiwi. Any?
Thank you so much, Dr. Ovu, for this all interesting outing this evening. I never knew that it's going to be this interesting. I think I learned so many things, a lot from this couple of hours that we spent together. Thank you so much for putting this class together and for all you do for those of us in this part of the world. Thank you so much. God bless you.
No problem. There's a lot of reading. I just put one article. Somebody mentioned, Dr. Oni, you were talking about immediate implants. So I put an article in the WhatsApp group. It's a very, very good article in terms of determining. I know you mentioned, you asked a question about how many implants in one. You need only one implant. You need only one implant per tooth. So just read the article and you will get some more from it. Any other questions? Any comments, any additions?
Yes, sir.
I've sent the link to this lecture. Okay, let me stop recording.